Hi everybody and welcome to the National Hispanic and Latino ATTC's webinar, an evidence-based practice brief strategic family therapy BSFT model. Today's webinar will be presented by Dr. Antonio Bustillo from Centro de Terapia de Familia e Hipnosis in San Juan, Puerto Rico. I will tell you more about him a little later. For today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure your computer speakers are turned on and off to hear today's presentation. We're going to review a few housekeeping items with everyone. If you notice that your viewer does not fit your screen, you can expand it by clicking the expand button located in the top right corner indicated by the red arrow. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking on the small red arrow to the left of the toolbar. And then click the arrow again to expand the toolbar again, and it will expand. Okay. As I mentioned, for today's webinar, all participants will be muted. As we move through the presentation, if you have a question for a presenter, we ask that you use the chat box on the toolbar. Simply type your question and hit send, and we will be pausing for our presenter to address questions throughout the presentation, okay? So we would like this to be an interactive webinar, so if you have questions, go ahead. And again, we can ask questions at the conclusion of the webinar. A recording of today's webinar along with the PowerPoint slides will be available at our website at www.attcnetwork.org/Hispanic Latino approximately 1 week from today. You can also find recordings and PowerPoint slides from all of our past webinars at the same URL. Also, we want to mention that one NIDA, one NBCC, and one ICNRC continuing education credit is available to those who attend today's live event. If you're interested in obtaining CEUs from this organization, please email us at hispaniclatinoattc@uccaribe.edu. Today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus areas ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And the 4 national focus area ATTCs are listed on the left of the screen. Today's webinar is the 17th in a series that the National Hispanic and Latino ATTC will be offering, and the first one of a series of evidence-based practices webinar. The ATTC network is funded by the Substance Abuse and Mental Health Services Administration and serves a critical role in improving the health of the United States. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. As I mentioned, the ATTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, that prevention works, that treatment is effective, and people recover from mental and substance use disorder. You can learn more about SAMHSA by visiting www.samhsa.gov. So now I'm going to introduce our presenter. Dr. Bustillo obtained a BA in Psychology from the University of Puerto Rico, Rio Piedra campus, a Master's in Psychology from the Inter-American University in Puerto Rico, and his doctorate degree with a subspecialty in Family and Couples Therapy and Hypnosis from the University of Massachusetts in Amherst. During his 24-year experience as a psychologist, he has worked in various clinical settings, including hospitals, outpatient clinics, and private practice in Puerto Rico and the United States. He was also a graduate-level professor at various universities in Puerto Rico and the United States. He obtained his license as marriage and family therapist from the state of Massachusetts in 1996 and obtained an advanced certification on brief strategic family therapy from the Family Studies Center at the Psychiatry Department at the University of Miami. Dr. Bustillo was trained as Marriage and Family Therapy Supervisor by the American Association of Marriage and Family Therapy. He has offered marriage and family therapy classes and certifications at various institutions, including Cambridge University in Massachusetts, Carlos Albizu University in San Juan, and the Universidad Central de Bayamón School of Medicine. Currently, he is in his 7th year, offering a 1-year certification in marriage and family therapy at the Renovation and Human Spiritual Development Center, El Buen Pastor, in Caguas, Puerto Rico. Dr. Bustillo has also extensive training and experience in the area of hypnosis and has presented at various forums on this subject. Okay. So now that we know a little bit more about our presenter, we're going to do some poll questions. Okay. We're going to ask our audience so that we can get to know you a bit better. Do you currently serve Hispanic and Latino populations with substance use disorders? And 83% say yes. Next question. Are you planning to serve Hispanic and Latino populations with substance use disorders in the next 6 months? And 88% say yes. Third question, which field of work do you represent? Substance use, mental health, primary care, education, policy, political affairs. And 53% substance use, 37% mental health, and 12% education. What is your current professional role? And we have 70% counselor therapist, 26% social worker case manager, 5% student faculty, and 3% government official or public policy. Next question. What type of setting do you currently work in? And we have 50% substance use treatment inpatient or outpatient, 13% university, 2% managed care, and 35% other. So now we're going to do a brief pretest with 3 questions, and the first one is, BSFT, Brief Strategic Family Therapy, has been proven to be an efficacious practice for Hispanics and Latinos, yes or no? And 100%, no. 95% say yes. Okay. Second one. BSFT includes mostly individual sessions and a few family interventions, yes or no? And we have 65% say no, 35% say yes. And the last one. When working with BSFT, the content is more important than the context, yes or no? And we have 79% say no and 21% say yes. Thank you, everybody, for doing that. So now I'm going to leave you with Dr. Bustillo, who's going to do our presentation. So I'm going to give him the screen now.
Thank you, Dr. Orovit. Can you all see the screen, my screen?
Yes.
Can you all see my screen? Can you?
Yes.
Good morning, everyone from sunny San Juan. All right, are we on? We said?
Yes.
Are we set? All right, I'm going to talk about brief strategic family therapy and evidence-based model in family therapy. Good morning, all again. My name is Dr. Antonio Bustillo. I'm going to start right away. What is brief strategic family therapy? Brief strategic family therapy, as we call it, BSFT, is a short-term, structured, problem-focused, and practical approach to interventions and treatment that targets families in which youth, usually from 6 to 17 years old, engage in a cluster of risk-taking or problematic behaviors, including drug abuse and alcohol, delinquency, affiliation with antisocial peers, unsafe sexual activity, and the accompanying maladaptive family interactions or relations. BSFT is an evidence-based modality for indicated populations developed over 35 years of research at the Center for Family Studies in the University of Miami, the School of Medicine, Psychiatric Department. BSFT has successfully reduced behavioral problems in adolescents and strengthened the families what provides the tools to overcome individual and family problems. It reduces risk and increased protection against adolescent drug use through focused interventions that improve maladaptive patterns of family interaction. I'm going to explain precisely why. Skill building strategies that strengthen families. It is important to establish that BSFT offers based on the premise that families are the strongest and most enduring force in the development of children and adolescents. As a matter of fact, it has been proven that families are essentially the buffer against risk factors in the community, healthy families, for children's behaving in unwanted ways and falling into drug or alcohol abuse. Why BSFT? It's an intervention that targets self-sustaining changes in the family environment of the adolescent. That's very important. I'll explain later on why. That means that the treatment environment is built into the adolescent's daily family life. We're going to work with that adolescent's family life and the specific interactions in the family life that are either developing or causing the problematic behavior or reinforcing them even inadvertently from the family members. Can be implemented in approximately 8 to 24 sessions with an approximate average of 12, maybe 13 in some studies. Has been extensively evaluated for more than 25 years and has been found to be efficacious in treating adolescent drug abuse, conduct problems, association with antisocial peers, and impaired family function. And finally, it's a manualized model for training therapy, so it can be reproduced through protocols and it can be evaluated through protocols of research. By working with families, BSFT not only decreases youth problems, but also creates better functioning in families, precisely changing those family patterns and interactions that either reinforce or sustain the problematic behaviors in the adolescent. Because changes are brought in family patterns of interactions, the changes in family function are more likely to last after treatment has ended. Because multiple family members have changed the way they behave within each other, therefore sustaining the new changes for a longer period of time. BSFT was formulated as an integrative model that combines structural and strategic family therapy techniques to address systemic relational primary family, but could include other community members, interactions that are associated with adolescent behavioral problems. It is important to note that the integration of structural and strategic approaches to family therapy led to develop a treatment that is problem-focused, it's planful, you can plan it ahead, and it's practical, focusing primarily on identifying and enacting the changes necessary to ameliorate the adolescents presenting problems. BSFT is a flexible approach that can be adapted to a broad range of family situations in a variety of service settings. That is mental health clinics, drug abuse treatment programs, and other social service settings. It can also be applied in a variety of treatment modalities, outpatient intervention, in combination with residential day treatment and as an aftercare or continuing care service to the residential treatment, of course, whenever the family of the adolescent can be involved in the treatment. It appeals to cultural groups that emphasize family and interpersonal relationship. Also, the very first studies concerning BSFT in populations were mostly or primarily conducted with Cuban American youth in South Florida and Miami. It has been expanded to other groups, Hispanic groups, and also it's been applied to different cultural groups that emphasize very strong bonds among family members and family relationships. Briefly, the goals of brief strategic family therapy, BSFT. First of all, of course, changing family dynamics, precisely to reduce or eliminate the adolescent's problematic behaviors such as drug use and other risk-taking behaviors. To change those family patterns of interactions that are associated, they might cause or reinforce with the adolescent's problem behavior. So basically, it's a family approach that wants to change the dynamics and be specific, targeting whatever the interaction and patterns that might be causing or reinforcing or sustaining the problematic adolescent behavior. Briefly, the conceptual influences on the evolution of BSFT. First of all, we have systems and communication theory. That affirms that a family is an organic system, so it's an organic whole, meaning that family members are interdependent among each other. So the whole family is a living system composed of emotional, interpersonal, physiological dynamics, communication dynamics of all sorts. So the family as a whole impacts each member of the family, and each member of the family has an impact on the whole. Structural interactional family therapy. The family structure offers a map according to which family interacts. That means that BSFT wants to evaluate what are the interactional patterns of the family dynamics that compose or create that family map, that structure where people are positioned in different ways and the way they interact and how it is affecting, reinforcing or causing the problematic behavior in the adolescent. Strategic family therapy, which means it's problem focused. And BSFT will want to develop specific interventions designed to address specific diagnosed structural problems that are congruent with the model. The social ecology theory of Uri Brenner, starting from the 70s, that it treats the adolescent in the context of his or her family and of the family in its social context. That means that not only the adolescent within its context of the family, but the family as part of the larger context, be the community, the social relationships of the family and the adolescents, be it the relationships among community members and the family, among school, among peers. Even in itself, the context of psychotherapy, family psychotherapy, is a context in itself to be included in BSFT interactions. Cognitive behavioral therapy is part of the conceptual influences, and it emphasizes the way families are perceiving, seeing, thinking, developing cognitions about a problem. And usually, when a family comes to therapy or when a family wants an adolescent to get therapy, their cognitions are mostly alienated to the fact that the adolescent, he or she, is the one having the problems and nobody else is having or contributing to the problem. So BSFT is very concerned about what are the cognitions among the individual members that sustain that view. An affective component. BSFT wants to utilize emotions and their expression pragmatically in the service of changing behavioral patterns and reconnecting family members to each other in a positive way. Pragmatically implies that BSFT is not concerned about analyzing in-depth emotions, however important, We want to approach emotions in the most pragmatic and effective way to create a positive interaction and context for better emotions in the family or within the family. The three core principles of BSFT, which I have mentioned already tangentially. The first is that BSFT is a family systems approach. Family systems means that family members are always interdependent, whether they are aware of it or not. The experience and behavior of each family member affects the experiences and behavior of other family members. According to family system theory, the drug-using adolescent is a family member who displays symptoms or problems, including drug use and related co-occurring problem behaviors. As such, the adolescent's behavior can be said to reflect maladaptive family interactions. These symptoms are indicative, at least in part, of what else is going on in the family, what other issues are going on in the family system that might be reinforcing or co-creating the problematic behavior in the adolescent. The second BSFT principle is that habitual or repetitive patterns of interactions in the family influence the behavior of each family member. Patterns of interaction are defined as the sequential behaviors among family members that become habitual and repeat over time. Therefore, it creates a structure, an interaction and matrix, if you may, that allows people to play sort of a role with expectations, ways of behaving, communicating, and acting. The third principle in BSFT is to plan interventions that are carefully targeted and provide practical ways to change those patterns of interaction that are directly linked to the adolescent drug use and other problem behaviors. That is, to target these repetitive maladaptive patterns of family interactions while strengthening adaptive patterns of interaction that will achieve the caregiver's goal of reducing the adolescent problematic risky behavior. And again, it's important because it emphasizes will achieve the caregiver's goal, i.e. the parents or caretaker, of reducing the adolescent problematic and risky behavior. And that implies in itself that BSFT is going to emphasize the involvement of parents and other family figures or caretakers in changing the dynamics that are reinforcing or causing the adolescent's problematic behavior. BSFT interventions are organized into four theoretical and empirically supported domains. The first one is joining. Joining is intended to establish a therapeutic alliance with each family member and with the family as a whole. Joining requires that the therapists demonstrate acceptance of and respect toward each individual family member, as well as acceptance of and respect toward the way in which the family as a whole is organized. This is very important because in BSFT, the first domain, the first duty of the therapist is to really join, to really connect, to step into the family world, the family notion of the world, the family values, and bring them to the therapeutic contract. In research, it has been shown that if you don't have a strong joining, if you don't make the family come to therapy, and especially all the members involved in some way in family dynamics that support or reinforce the problematic behavior, the tendency is going to be for the family to drop out of therapy or not being consistent with therapy, and effectiveness is going to decrease significantly. So BSFT therapists are trained to really go the extra mile, to really get some specific skills into joining with the family and bring them into a therapeutic encounter. Tracking and diagnostic enactment interventions. In BSFT, these interventions are designed to systematically identify adaptive and maladaptive patterns of interactions and to use these patterns of interactions to build a treatment plan. The core feature is that the therapist encourages family members to behave as if they would if the counselor were not present. In other words, the BSFT therapist gets specialized skills into tracking, following the sequences of family interactions of natural enactment as better as possible, allowing the family to interact in his or her office or setting as if the therapists were not there, to be as best possible to capture those interactional patterns that are not healthy, that are cognitively or emotionally or structurally reinforcing the problematic behavior, and then make a diagnosis of those enactments and put into several categories that I'm going to be explaining about, diagnostic categories, and we lead the therapists, the BSFT therapists, to develop this specific and planned intervention targeted at that specific process of the family. Reframing. Reframing interventions are utilized to reduce negative affecting family interactions while creating a motivational context for change. Because reframing, by promoting constructive interaction, creates a motivational context for change. It serves as a natural springboard for restructuring. And I'm going to get back for the reframing here. So the BSFT therapists get very skilled in tracking interaction, making good diagnostics or diagnosis about what are the patterns that provide the interactions, what are the structural issues in the family that are either creating those patterns that you already tracked down and or reinforcing them. And then it also gets specific and specialized skills to reframe whatever interaction might bring in very negative aspect. Reframing it, the therapist create a context for motivation for change. And that leads to restructuring, which is the last part of the process, the therapeutic process. Restructuring interventions that transform family relations from problematic to effective and mutually supportive. Again, now the therapist is restructuring, is showing, allowing the family to behave in a different way, in a very specific and different way within the therapeutic context. So that it's going to become some sort of a blueprint of a new template, if you will, for families to behave in different ways, with different conditions, different and more positive affect to whatever the issue at hand, and create a healthier, so to speak, a healthier supportive atmosphere in the family. Such a structuring intervention includes directing specific members of the family to do something or say something differently, redirecting, blocking communication. That's important because sometimes the therapist might be able to not allow somebody to communicate in the same non-positive or negative way. Changing family alliances that might be inadvertently supporting or reinforcing the adolescent's behavior. For instance, whenever an adolescent, or whatever the reasons, have too much power within the family and one of the parents or caretaker doesn't have any, the BSFT therapists need to be very skillful into therapeutically change that alliance and put both parents, if they're both parents, in charge, and put and elevate their role and the status in a positive way as the caretakers of the family. Helping families to develop conflict resolution skills is very important. Developing effective behavior management and conflict resolution skills. And fostering positive parenting and parental leadership skills. Again, if you notice, BSFT springs for the notion that the family is the most effective and should be the most effective parenting institution for children and adolescents, more encouraging institutions. So BSFT wants the parent or the caretakers to be leaders, to lead, to provide the necessary emotional, psychological, interpersonal, interactional tools to help the child and adolescents develop adequately positively.
Dr. Bustillo, we have a question.
Basic concept, and again, this is a very brief sketch. The context, as Bronfenbrenner explained it, the great beauty of Bronfenbrenner from the late 70s all through the late 80s. And it could include, of course, the family, their peer system, the neighborhood, their culture. Why culture? Because it's important to be very attuned to whatever the cultural context, the values of the family, the notions, the belief systems. The counseling setting itself is a context which is extremely important when the therapist needs to establish a therapeutic alliance and engage the family into the process. Could also include school context, maybe religious or belief system context.
Dr.
Systems
Bustillo, we
which
have a
always
few
implies
questions.
families' assistance with interdependent and interrelated parts. Family influences may be experienced as an invisible force shaping the behavior of its member with rules, values, expectations, alliances, communications. That means that usually people that are trained family therapists know this as a core value, core concept in family therapy. But those who are listening and doesn't have any training, the important is that the system's notions permeates all over the BSFT model. Structure, again, it implies patterns of family interaction that are habitual and repeated behaviors family members engage with each other, or all families work upon a structure, some sort of a structure of established pattern of interaction. Some of them can be very healthy, very functional, some of them are regularly or average functioning, some of them are very unhealthy, some might say chaotic, and the unhealthier, the more unstructured and the family pattern, the most the tendency for members, especially children and adolescents, which are most of the time the more vulnerable will be prone to problems and problematic behaviors. Basic concept of BSFT, again, the strategy. BSFT interventions are strategic, based in the work of the great J. Haley and Chloe Madanes in the 70s and on to the 80s, in that they are practical, problem-focused, and planned. So the BSFT therapist doesn't want to waste any time just wandering, free associating within the therapeutic context. It tries as much as possible to delineate, to diagnose whatever the unhealthy family patterns, and then change them in the most specific and planned way possible. It is practical. It uses strategies to work quickly and effectively, and it's problem focused, which is part of the strategy. It works to change maladaptive interactions or to augment, increase existing adaptive healthy interactions. That is, when family members interact effectively with one another, but maybe the therapist need to help the families to increase those healthy behaviors. For instance, I've seen many families that they're doing very healthy things, but they don't do it like consistently. They don't have a way of doing it over and over again as a pattern. So they might be doing it more randomly, more connected to external or casual things than becoming a pattern, a repetitive pattern out of it. And that are directly related to the presenting problem. In this case, the adolescent drug use, alcohol use, or whatever other antisocial problem might present. BSFT again is planned. In BSFT, the counselor plans the overall counseling strategy. You may go, all right, overall counseling strategy, and the strategy for each session in a clear, well-organized way. Again, the therapist gets very specialized, very skillful in tracking down communicational and behavioral patterns and diagnose those patterns within the structure of the family, and then reframe whatever negative affect there might be, whatever negative cognitions might be associated or linked to those negative patterns of behavior, and then restructure it. So it needs to plan ahead the best way possible, what's going to be the well-organized way to help the family achieve those goals, those therapeutic goals. An important issue regarding BSFT. BSFT always is going to regard process over content. That is to say, instead of working with what the content, right, what the family is talking about, as classical psychoanalytic approaches, is talking about how people process, how people interact among each other, like the degree to which family member listens to, support, interrupt, undermine, reinforce, and express emotions to one another. So BSFT favors process over content, favors the way the family is interacting in enactments in the family within the therapeutic session to see how health therapists delineate what are the necessary changes needed in those patterns of interaction, that in the structure that supports them to create healthier ways of communicating and behaving within the family. The diagnosis in BSFT. So therefore, diagnosis in BSFT are very congruent with the whole schema, the whole model. I made on the dimensions of organization, that means hierarchy, patterns of alliances between and among family members, who talks to who has power or decision-making power over who sabotage the power or the influences of whom. The resonance, which is the extent of emotional closeness or distance between specific family members. Families where there's too much fighting, there's too much closeness on fighting, there's a very heavy, high, but negative resonance, and that doesn't help. Families that are very extremely disengaged, that the caretakers do not pay attention to whatever the adolescents are doing, there's a very low and negative resonance. They don't care about each other. They're not checking on each other, and especially they're not checking on the kids. So that's important. The developmental stage, the age appropriateness of family roles. For instance, if you check the literature on the family life cycles, it is important that all healthy families get to do some specific goals, some specific roles on each of the different family life cycles, and of course, it's got to be connected to the age appropriateness of each individual. So BSFT is very helpful in evaluating where's the developmental stage of everyone in the family, included the person with the problematic behavior, and where is this family in the family life cycle. The life context, conditions affecting the lives of the family or its members, such as divorce, which is a great issue among the U.S. families and also in Puerto Rico, and the deaths of somebody in the family. Crime-ridden neighborhoods, which is very important, so BSFT tries to look at it and try to evaluate what's the impact on the adolescent. What we call in BSFT the identified patient code, the IP code, which is the extent to which a single family member, in this case the adolescent, is blamed for all the family problems. What we call, for instance, a lot of families, especially parents, will come to the office and we say all of our problems are caused because this kid is doing so and so, because the kid is doing something like that. And they really believe that. They really have locked into that idea that the children or the adolescent is creating all sorts of problems, and the children and the adolescent is responsible for whatever is happening in the family. And finally, what we call conflict resolution style. BSFT wants to evaluate how the family is dealing with the problem. Is the family aware of the problem? Are they in total denial of the problem? Do they diffuse the problem and start talking about the problem, and then 2 minutes later are talking about anything else but the problem? Do they have the tools to recognize the problem? If they only see the identified patient, so to speak, or the child with the problem as the only family problem, do they have some interaction and perspective about if they are in some way contributing to the problem? Some families can identify the problem, but doesn't know what to do about it. So some families might say, yeah, we have a problem, but from then on doesn't have any idea how to deal with it. Some families can resolve in a moderate way the problem, or maybe put some temporary solutions, but not be able to sustain those behaviors that solve the problem. So BSFT wants to be very clear on what is the conflict resolution style of this family. Outcome studies. Briefly, BSFT has been found to be efficacious in treating adolescent drug abuse, conduct problems, associations with antisocial peers, and impaired family functioning. Randomized clinical trials evaluating the efficacy and effectiveness of the model and identifying specific therapist behaviors that are associated with the most favorable adolescent and family outcome has been conducted for BSFT, two of them at least. BSFT is one of the model programs of the United States Department of Health and Human Services, and is included in the National Registry of Evidence-Based Programs and Practices for Family Therapy regarding these programs to adolescents. It's important to mention that also, as I mentioned earlier, also the initial studies were conducted with Hispanics, basically all of them Cuban families in Miami. BSFT has been effective research and suggested that the model is equally applicable to African American, Hispanic Americans, and White Americans. It has been applied also. I have the privilege to work with BSFT some 6 years ago in Puerto Rico, and we apply it to local population in Puerto Rico with good results. And the model is currently being used broadly with a variety of populations in Europe and the United States and several countries in Europe. Efficacy studies. Two randomized control studies, one study found BSFT more efficacious than individual psychodynamic child therapy and a recreational or placebo-controlled condition after 1 year of treatment follow-up. On the second study, BSFT was more effective than group psychotherapy for Hispanic adolescents, Cuban and other countries or Hispanic countries. The BSFT condition was significantly more efficacious than group counseling in reducing conduct problems associated with antisocial peers, marijuana use, and in improving observer ratings of family function. BSFT engagement, this is very important, as I mentioned earlier. In BSFT, the therapist wants to work extra hard and wants to develop specific and special skills to bring in families to therapy, to engage them, to join them as best as possible to retain them in therapy. In a study with Hispanic adolescents conducted by Zapotny et al., 93% of the families in the BSFT engagement and 42% of the families in the engagement as user condition show treatment engagement. This treatment engagement is defined as all family members in the household attending an admission session. Of the 93% of BSFT, 75% completed treatment, and only 25% completed treatment on the other condition. That means that the higher the rate of engagement, the more possible that the higher number of family completed treatment and getting more results. In another study by Esteban et al., in 1996, families were randomly assigned to a BSFT engagement or engagement control group, what they call no special engagement condition. The BSFT engagement condition, 81% of the families were successfully engaged, again, defined as attending an intake and a first therapy session, compared to 60% of the engagement in the control condition. And again, this cannot be overemphasized. The family therapy studies show that the more commitment of families to come into therapy, especially with all the members associated or related to the problematic behavior that we want to help the adolescent overcome, the better the chances of effectiveness. Conclusion, BSFT is an evidence-based model for working with adolescent and drug and conduct-related problems and their families. Implementing this model in the community settings will provide therapists with an effective tool to increase family involvement in therapy, increase retention, reduce adolescent drug and use and related risk-taking behaviors, and reconfigure family interactions to support healthy development. From my point of view, the importance of BSFT and my experience with it applying here in Puerto Rico is that it's an excellent model that can be teachable and can be evaluated through protocols that gives the therapist specific skills to join, to diagnose, to track down interactions, to develop specific skills for develop specific intervention strategies targeted at specific issues, i.e. problems, interaction, and communication patterns, structural patterns, to change family dynamics in the here and now, in the present with the families, in the office, and allow the families to learn those new interactions, practicing them, and then go back to their lives and put them in practice. And the therapist can, in the next session, review whatever works and what are the things that need to be reevaluated, what are, if there are other interventions to develop. And the importance is that it's a well-planned strategic model to follow through the process of families learning new engaging behaviors, new healthy ways of engaging behaviors. So that's a presentation. If anyone has a question.
Thank you, Dr. Castillo. Can you hear me?
Are you listening? Are you listening?
Yes.
Hello.
No.
Can you hear me?
Yes, we're here. Okay.
I'm okay. I hear you pretty cool.
Okay, good. We have a few questions. Okay, so I'm going.
Sure, please.
Okay. The first one is, would you say that content versus process component applies to resiliency training as well?
Well, that's a great content versus process. Well, that's a great question. Well, I think in resiliency training, you wanna apply it to. I think it does apply in resiliency training. Resiliency, if you translate it into family systems, is, for instance, resiliency in a family is what are the things that the families are doing, thinking, talking, behaving, feeling about, that is helping them overcome a problem, right? So if the therapist doesn't know how to help the family be aware of those processes, of those things that they're doing, and they cannot reproduce them, there's not going to be consistent resiliency and growth. So I would say that process over content is equally important in resiliency training. I think thinking specifically about families. For instance, I have worked with a lot of families that they can be very resilient, but they're not consistent enough to keep the changes going. So I would say it could be applied. That's a good question.
Okay, great. Another question regarding joining. How can you work with a family member who doesn't want to come to therapy?
That's a great question. And specifically, I'm very proud of this model because I think that better than any other model, BSFT really works hard with the therapist, developing skills to bring in the people that needs to be in therapy in the session for really changing family structures and dynamics. So BSFT therapists work from the first call on to let that parent know that their opinion, their input is very important, is as important as the others. For instance, I see a lot of family where especially men, Hispanic men, they don't want to get into therapy. That's not for them. That's for women or kids or whatever. And a lot of them, they won't tell you, but a lot of them think that their opinion is not important, that they don't have any say into whatever is going on. For instance, if you look at the traditional model of families, right, usually the mom is the caretaker, the one that raises the child, and the father is the breadwinner and so on. So there's a lot of parents that need to be told that they're very, very important. So as a therapist, as a BSFT therapist, I want to emphasize that from the first phone call. I want to ask them to come in to let me know their side of the story, their angle of the story, however if it's healthy or not at this point. So BSFT works specifically hard to bring in therapy all the members included in changing the dynamics, the problematic dynamics. So it's always a challenge, but I do believe that realistically speaking, it's not magic. This model emphasizes that in therapist training better than anyone else. I would say that, but it's a very good question. It's always a challenge. There are families that are impossible to bring in, and there's families that with a lot of work they might come in at least to give you a try to see what this guy or this woman is about, what this therapy is about.
Okay, good. There's another one regarding joining. What techniques does the model provide to join members, especially parents or caregivers, in a way that they don't feel blamed for the adolescent's behavior?
Oh, that's great. Well, the techniques are many, but for instance, right from the phone call, we want to assure parents that they're very concerned about their kids, their adolescents. They're needed in the kids' life. They're the ones. They're the bosses, not in that way, but they're the ones in charge. They're the one that I need to be listened to. They're the one that I need to listen to their worries. So we emphasize their importance of the heads of the house. And their importance. So we don't blame the parents for the kids' behavior. We talk about the resiliency in families, the way that families and researchers in family therapy shows that the family is the best buffering of kids and adolescents for risk in the community. So we emphasize the importance of them as family members, as loving people. So we try as much as possible to avoid blaming the parents into whatever is going on with the kids. So we want them involved as tools for the kid to overcome that problem, which is a totally different take on the issue.
Okay.
And we work as hard as possible with that.
Okay, thank you. We have another one. Since this aims at working in relationships in the here and now, would you say that BSFT requires coaching skills?
Coaches, well, you could call it some sort of coaching skills. I don't want to step into the coaching models, but yeah, the therapist is orchestrating, directing, and BSFT assumes in a healthy way that the therapist is the expert in therapy. The family is they are the experts in their life, and we have to collaborate, and the therapist wants to be direct whenever possible to help the family interact differently. So yeah, it coaches, it brings changes, it moves people around the office, it changes alliances. So it takes responsibility for the therapist to help the family overcome or change the interactional patterns. So yeah, it kind of coaches. I like to think of it. My training from the University of Miami used to say that it's like a play, a theater play, right? So the director is helping the actors. You should stand here, you should stand over here, you should, move your head up and talk in this way, use this tone of voice. So yeah, there's a lot of directing and you might say coaching involved in creating new patterns, new enactments for the family.
Okay, thank you. For counselors working in an agency with limited 2 to 3 family sessions, how would you recommend prioritizing issues using BSFT?
Oh, that's very hard. That's a toughie. Well, to be honest, that's a very toughie. It's so limited. So I would say in a realistic way, I don't want to be in a magical way, that if any family model could be useful at least up to some degree because of the limited session, it would be BSFT. For instance, not to say that with 3 sessions you can do a lot, to be very honest. For me, that's so hard. It breaks my heart. Whenever an agency just give a therapist just 3 sessions to work on the family. But for instance, BSFT has different skills that the therapist could start applying from the phone call and getting information, some sort of information from whatever is going on in the family, in order to help maximize, however small numbers of sessions available. But to be honest, 3 is like way tough, way tough. It allows me for another conversation that we can have right now about, economics and psychotherapy and our nation. But it's a tough one. 3 sessions is very, very hard.
Okay. I think we have time for another one. What about BSFT do you think makes it an appealing model for Hispanic families?
Well, BSFT was born from Cuban adolescents living in the Miami area and the surroundings. So actually, Dr. Jose Zapone, which is the creator, and his colleagues of BSFT, is a Cuban-Russian psychologist. I think he's from Russian descent and Cuban. So he was born from the need in the Miami and the Dade County that were having a lot of adolescents, Cuban adolescents, where some of them were English speakers, but not their parents were English speaking. And they were having problems with the law, having problems at school, having problems with drugs. So they start creating, right from scratch, the model. Of course, they took it from all the different influences, therapeutic influences that I mentioned. So I think in the States, it's one of the, if not the, family model to deal with Hispanic minorities. It's totally sensitive to that. And then they expanded to other Hispanic groups in Miami. As you know, there's a lot of Hispanic groups now in Miami, and then they did some research in Puerto Rico where I got involved with them, and we tested the model for about 2 years. They trained us, and then we tested the model for about 2 years, and now they're expanded into some countries in Europe. So I would say it's right on target. It's right, the model to deal with Hispanic youth within the United States. I would say that's for sure.
Mm-hmm. Okay. I'm going to ask one more question, and I want to let the audience know that the other questions, we're going to have the answers on our website. What I'm going to do is I'm going to send them to you, and then we can post the answers on the website, okay?
I'll be glad to.
Okay, so the last question. Would this model be effective for families who are living in separate homes? Example.
That's a great question. I'm so glad somebody asked it. I think it would, listen, families, two-parent or two-household families are extremely complex, because you don't have all the members living in one same place. So I would say it would work, assuming that you have the commitment of both parents or people in charge of the two households. It would be probably more challenging, more complex, but it would work. I mean, especially if the families if you could see at some point the different adults even in the two households, it could work. So I would say I would do it. I would say it could work, but you need to be more careful, because you have to evaluate more context, more relational context when you have more than one household.
Okay, great. Thank you so much. So as I said, the answers to the rest of the questions and to the ones that we answered right here will be available on our website. And I want to remind everyone that a recording of today's webinar and PowerPoint slides will be available at our website again at www.attcnetwork.org/Hispanic Latino. And again, Dr. Bustillo, thank you so much for your time and
My pleasure.
For answering our questions. And for our audience, this concludes today's webinar. I would like to thank again Dr. Bustillo, and remember to look at our website for future webinars. As you leave today's webinar, you'll be directed to complete a brief survey about your experience. Your feedback is very important to us, and we appreciate you taking the time to tell us what you thought of today's webinar. So thank you, everybody.
Thank you again. Have a great day. Love and peace. Bye, Dr. Arovich.
Bye.